I've titled this talk After the Dust Has Settled, and I'm going to be talking about COVID-19 outcomes, largely excess mortality, and the Global Health Security Index, and then also touch on some issues of pandemic strategy and some structural determinants of outcomes by the end. But I really just want to step through the problem of preparedness indices and COVID outcomes, what some of these the previous studies findings were, and some of the issues associated with that. And then basically outline the methodological challenge. And I want to dwell on that point just a little bit because it explains why we did what we did. And then I can present our findings and the broader context as well, and some lessons for the future. So let me just advance this. So yes, as I mentioned in the introduction, the Global Health Security Index is a metric for assessing pandemic preparedness. It's split into basically six categories, as most of you well know, I'm sure: prevention, detection, response, health system, international norms, and risk environment. First created in 2019 with an update in 2021. It has face validity because it was based on extensive literature reviews and so forth at the beginning, and it draws upon a very broad range of publicly available data across most jurisdictions in the world to create this index, which provides a score out of 100, both at the overall score level and across these different categories as well. And each category breaks down into a number of indicators and sub-indicators. There has been some validation work, empirical validation of the index, and just one example here is one of our own papers from 2020, where we basically did some regression analysis and determined the association between, hopefully my laser pointer shows up here, between increasing GHS index overall score and a lower proportion of the population, or proportion of deaths attributable to communicable diseases. So it seemed to have some empirical validity there, with a plus 10-point raise in index scores being associated with about a 5% reduction in the proportion of deaths attributable to communicable diseases. Given this background, you would expect perhaps that jurisdictions with a higher Global Health Security Index score might suffer less death in the COVID-19 pandemic. So, sorry, my pointer. There we go. So, early in the pandemic, some studies looked at exactly this question. And so, if we look over here on the left, taking in this example OECD countries, the blue bars here indicate the rank ordering of jurisdictions according to their Global Health Security Index score. So right down here, we've got the US and the UK with the highest scores, the first rank 1 and 2, and then in the orange bars, we've got a composite metric of pandemic outcome, and you see that the worst outcomes seem to be associated with some of the best scores, and there seems to be really no relationship between the orange bars and the blue bars. So the argument there was that there was no predictive power, or no association between the index and outcomes. Turning to Africa, we see similar things. We've got this cumulative deaths versus GHSI index here, which has a positive correlation, indicating that higher scores were associated with more death, not what we might have expected. And then similarly across a wider range of countries around the world, again, we've got this association with a higher GHS index score and more deaths. So, the argument was that this index had no explanatory power early in COVID. And so, what might be going on there? Well, one thing we do know is that there's various different metrics we can be looking at for pandemic outcome. We can look at reported deaths or reported cases, things like this. But we can also look at, excess deaths, which turn out to be different to the reported deaths. And you see on a graph here from Our World in Data, just illustrating for 3 countries. This varies country by country. The baseline here being the sort of expected death, and the line tracing the excess death that was actually determined. But it doesn't just vary country by country, these data, but it varies systematically. So in this study by Neumeyer in 2022, we see that the data varies systematically according to liberal democracy score. So what we're seeing here is the red dots representing the reported mortality and the blue dots representing the excess death calculations. And we see that where jurisdictions have a high level of democracy, there's a much narrower gap between the reported and excess death compared to countries right down the other end of the democracy score, where there's this very wide gap. So these sorts of things need to be accounted for and adjusted for in analyses of what's going on here. So some studies actually started to do this. So there was a good first attempt to untangle this by Ledesma et al. In 2023. In a study that corrected for mortality reporting issues by using excess deaths and calculating comparative mortality ratios based on a reference population. And also adjusted for population age structure as well, which is important to do when comparing jurisdictions, and controlling for wealth for GDP, and doing those adjustments, we now see, after the dust has settled a little bit, this association between higher global health security index scores and lower comparative excess mortality ratios, which is a bit more like what we might have expected ahead of time. And this was found not just for the overall score, but also, as you see in the panel here, for I think 5 of the 6 category scores as well, where a higher score in the category was associated with lower death. So that seemed fine. That seemed to be what theory would have predicted. However, the study was not without its criticisms, and this paper by Determinants et al. In 2024 pointed out that actually, if you're doing linear regression, you really need to be really careful that the assumptions of linear regression are satisfied, and these include, in particular, assumptions of linearity. And so, just one critique of this sort of analysis is basically, when you've got some data, as is illustrated here in the left panel, for GDP for wealth, that's very skewed, with lots of nations having a lower GDP and just a few with these very high ones. If you try to fit a line, as you must do for linear regression to this, you really can't fit a line that represents that data very well. We've got this very high variance here over here on the left, and the line doesn't really capture what that data is all about. If we log transform the data, though, we are able to fit such a line. And so the argument goes that basically you need to examine these variables very carefully and apply appropriate transformations. And it's not just an academic point, because what this paper actually did is it repeated that Ledesma et al. Analysis that I just mentioned. And if we look at the overall score here, what they found is if they repeated exactly what Ledesma did, they get this negative association between the index and death, which is what you'd expect: higher index scores, lower death, which is statistically robust. But then when they log transformed the income adjustment data, the statistical robustness of that finding actually disappears. And the argument in this paper was that it actually disappears across the board when you do this, with the exception of, here's just a snapshot from the risk environment category. It disappears except for this government effectiveness item, which maintains a p-value that meets the multiple comparisons threshold that they used, in these analyses. And it's not surprising that government effectiveness maintains its association here, as we know from earlier research. For example, the COVID National Preparedness collaborators' work, that things like government corruption, trust in government, and trust in individuals were associated, or were some of the only robust associations with pandemic death. So these probably fall in this sort of government effectiveness type category. So it seems like we're back to square one. How are we going to untangle this? But maybe something else is also going on, and here's where our thinking starts to come in. We wonder if a subgroup of the jurisdictions under study might systematically differ in their pandemic experience from other subgroups. And so if we cast our minds back to the 1918 influenza pandemic, here's just some data here demonstrating for among islands, those islands that implemented a strict maritime quarantine in the blue squares here, represented by blue squares, had a much later arrival of the pandemic. This is date along the x-axis, and much lower death, almost zero in this graph, compared to islands that did not institute this strict quarantine. Now, this is effectively, border closure with quarantine, as we're familiar with what some islands did during COVID-19. And just reproducing a table from our paper here, we see that during the first 2 years of the COVID-19 pandemic, islands have a much lower cumulative across those 2 years age standardized excess mortality of 59 per 100,000 versus non-islands, which is more than triple that at 193 per 100,000. So yeah, we really started wondering if running these analysis separately for islands and non-islands might be the thing to do. And just sort of theoretically, we hypothesized that maybe something like this is going on. You've got a group of a population of jurisdictions where we're seeing no significant trend when we're doing the appropriate adjustments, but perhaps that population is composed of subpopulations, perhaps non-islands and islands, that are showing opposite trends on some phenomenon, and that's why we're not able to see this when we analyze the nations or the jurisdictions of the world as a group. So, given the foregoing background, we had the following research questions. We wanted to understand whether relationships between the Global Health Security Index scores and excess mortality remained after appropriate transformations, not just of GDP, but any other variables that might be skewed and so forth. Whether there were any associations between the index scores and macroeconomic performance, so not just health outcomes, but also GDP growth. And importantly, does consideration of island and non-island jurisdictions separately reveal any important patterns in this analysis? So our method, basically, we tried to do a pretty robust analysis. So we took data from as many jurisdictions as we could, most countries from around the world. We looked at cumulative excess mortality, not reported deaths. We ensured we were using age standardized data with log transform of the skewed variables such as GDP, a cube root transformation of excess mortality, which is also very skewed, but you can't do a log transformation here because 7 jurisdictions show a negative excess mortality, and that won't work for a log transformation. And you want to maintain those negative values because that's important data. We separated islands from non-islands. Evaluated GDP growth as well. And we included some theory-based controls, in particular wealth, which is shown to be associated with outcomes previously. Corruption as a metric of government corruption as a metric of governance effectiveness. And in some of the analyses that I'll mention as well, also population size and indeed controlling for the Global Health Security Index to control for preparedness. And we did this hierarchical analysis. So because of the number of indicators and sub-indicators and so forth, there's a lot of comparisons to do, and you don't want to sort of be, p-hacking or messing up the estimates of statistical robustness. So we began with the overall score. If that showed an association, we would then move to the category scores, and then for those categories and those groups in our analysis that showed a statistical association, we would then take the indicators and so forth forward for analysis as well. So that's what we did. And here's the data we used in this analysis. So the age standardized excess mortality came from the Global Burden of Disease Study demographics collaborators. And this is a pretty robust excess mortality data set. They've actually used even, ensemble models to, weighted ensemble models to mitigate for, any potential trends in the data across time rather than just taking 5-year means or whatever. The details can be talked about. But, so this is a age standardized excess mortality global data set. We used GDP purchasing power parity data from the World Bank, the GHS index, obviously, the 2019 iteration, because the 2021 iteration had actually already been informed by some of the happenings in COVID-19. So there's a consideration of circularity to some degree if we started using the 2021 index. Uh, and the government corruption variable, we used that data from the COVID-19 National Preparedness collaborators. They had done some principal components analysis of corruption surveys, and similarly for trust in government and trust in individuals. As you'll see, the sample size reduces quite a lot when you start including these variables because they're not available for every jurisdiction. So just to talk a bit about the data before we get into the results, you can see here on the right, this is the GDP data that we're using both before and after the log transformation. So that skew kind of disappears a bit. And this is the excess mortality data both before and after the cube root transformation. So that skew as well disappears. And you see these negative excess mortality jurisdictions down here. And the data coverage. So for the main variables, the excess mortality, the GDP growth, and the GHS index scores, we've got data for most jurisdictions, around about 180 or 200 jurisdictions. And then when you break this into islands and non-islands, you see that islands make up about a third of the sample. With the control variables, GDP is available for most places, but once you start adding in government corruption, and particularly when you add in trust in governments and trust in individuals, these sample sizes decrease a lot. So it's hard to probably generalize from the islands sample once you've added all these controls, and similarly for non-islands as well. That's an important point, and talk about that a bit as well. So what did we find? Well, look, we had three groups. We had all jurisdictions, and then the island jurisdiction group within that, and then the non-island jurisdiction group within that. And we had three dependent variables, three outcome variables: the cumulative excess mortality, the GDP growth in the first year, and the GDP growth in the second year. So that gives us 9 analysis families. And so we adjusted our p-value thresholds, statistical robustness thresholds accordingly. We had 3 models as well. So the first model, model 1, these are numbered in the second column. Model 1 is basically just repeating the Ledesma analysis, so no transformations, and using the 2021 index. Model 2 is doing what the Dillerman paper recommends, so using the 2019 index and transforming the skewed variables. And model 3 is a model where we included the government corruption variable as to moderate for effectiveness of implementation. And so what we found for all jurisdictions, as with the previous analyses, under the Ledesma process, we found this negative regression coefficient, which is what you would expect. So higher scores on the index, lower death, negative association, and it's statistically robust at this quite low p-value. But when we applied the transformations, as Dillerman's paper suggested, this disappears, right? There's no longer any association as was predicted by that paper. However, when you separate islands and non-islands out of that all sample, you see that there is no statistical association in islands, but for non-islands, the association persists in the expected direction under the Ledesma type analysis, under the Dillerman corrections, and even when adding in a metric of government corruption or effectiveness. So we still see this relationship in the non-island sample quite clearly. So what does this mean? Well, what we've done is taken those regression results and constructed a predicted excess mortality figure here, which shows that for along the x-axis is what we've called starting excess mortality. So for a hypothetical nation or jurisdiction with a 100 per 100,000 excess mortality during the first 2 years of the pandemic, if that jurisdiction were to have a, say, 10-point increase in their preparedness index, the Global Health Security Index score, you would expect to see approximately 26 fewer deaths per 100,000 in excess mortality based on those findings. So for a country of 10 million people, that would be 2,600 fewer deaths if that country were to have a higher preparedness index score. So that's the prediction based on the regression analyses we've done, and this panel over on the right here demonstrates the relationship for non-islands. This is all just for non-islands. Relationship between index scores and the age standardized excess mortality. And what we see here is for index scores over 60, we've got all this cluster of jurisdictions here that are below the regression line. And for index scores below 40, we've got this cluster of jurisdictions here above the regression line. So you're really seeing this trend from high to low excess mortality, as index scores increase. For non-islands, for islands, we see no such relationship. So something else is going on with islands. So moving on to just the second level of that hierarchical analysis. So that was just the overall score. We took forward for the second level analysis the category scores. So this is prevention, detection, response, etc. within the index. The category scores just for non-islands, where there had been a significant relationship at that first level. We didn't look at islands because there was no overall relationship. What we see here is that for non-islands, with the transformed variables across the category scores, we're seeing coefficients that are all negative, all in the theory expected direction, higher scores in each category associated with lower excess mortality. 5 of the 6 categories, the starred ones here, have p-values after correction using a Benjamini-Hochman correction, because we're now expecting things to be correlated and we're expecting associations. After adjustment, statistically significant. So this is the story that we would have expected a priori before the COVID pandemic, based on the early validation against communicable diseases for this index. And we're seeing sample sizes here of 128 jurisdictions with data across all the variables required for this analysis. And then we've done the sensitivity analysis as well, where we included all the control variables, not just wealth and government corruption. And as you see here, for all jurisdictions in the sensitivity analysis, including corruption, trust in government, and trust in individuals, there's no robust association. But for non-islands, for that analysis, we're seeing this negative coefficient. The coefficients here look quite small, but that's because of the cube root transformation, which reduces what you're used to seeing in excess mortality. And we've got this significant statistical association here. Interestingly, this model is now explaining 68% of the variance in excess mortality. So once you've included wealth, corruption, trust, and preparedness index, you're explaining 68% of the variance in excess mortality. Moving on to the indicator level scores. So again, thinking about the assumptions of linear regression, if we're using regression models in this analysis, the data really needs to be it needs to be linear, for example, as one assumption. And we're not really seeing that when we visually inspect a lot of these indicator scores. We're seeing bimodal distributions, we're seeing skewed distributions, and we're seeing even some indicators where there's almost a monolithic score that every jurisdiction scores the same. So these indicator level scores, I would be hesitant to deploy linear regression without significant transformation or a different analysis approach across the indicator scores. So we actually didn't delve into those, and I'd have a healthy dose of skepticism for claims of any associations with indicator scores just based on a pure linear regression. And just very briefly on the macroeconomic stuff. So although a statistical association persists in Model 3, so this is the model adjusted for government corruption with the transformations, an association persisted for all jurisdictions and GDP growth in the first year of the pandemic, where higher scores predicted a shallower contraction in GDP growth. Taking this forward to category scores, model fit was really poor, explaining only about 5 or 7% of the variance. So something else is going on driving the GDP impacts in COVID-19 beyond the sort of variables we're analysing here. All right, so just very briefly, I want to talk about just 2 other papers, just a slide or so on each, where now that we've developed this method, these transformations, this data set, and this approach, we then started deploying this across some other data as well, including control strategy. Pa- Sorry, can someone just, yeah, thank you. Pandemic control strategy, border closure strategy, and democracy and inequality. So I'll just show one graph on each of these, basically. So uh, we know that different jurisdictions had different approaches to the pandemic. Some jurisdictions tried to mitigate the impact. Some jurisdictions articulated an explicit exclusion and elimination strategy where they sought to exclude the virus through border controls of various sorts and to eliminate any outbreak completely to return to zero community cases. The countries that articulated explicitly that strategy were Australia, China, New Zealand, Singapore, and Taiwan. And what we see is when we look at the age standardized excess mortality cumulative across the first 2 years of the pandemic for those 5 jurisdictions, the mean is negative. It's -2 per 100,000 excess mortality compared to all other jurisdictions which had this excess mortality, which breaks down into non-islands with a higher excess mortality and islands with a lower excess mortality. Now, there's only 5 of these explicit exclusion elimination countries, so it's hard to do statistical tests across this data, but it just is interesting that those 5 averaged negative excess mortality. Partly this was due to border control strategies. And so when we turn to border strategy, what we've got is, according to the Oxford Stringency Index, we used their data. They categorize border controls as on a 1 to 4 scale. I think it might be 0 to 4, with 4 being the most stringent. So this is where you basically don't allow people across the border, or there's strict quarantine, requirements in place. So among the and actually at some point in the pandemic, 80% of jurisdictions actually implemented for at least some period of time this kind of strategy. A lot of them abandoned it quickly, of course, but some persisted with it for a long time. When we look at jurisdictions that use this level 4 border strategy, comparing non-islands here in red in the left-hand panel and islands in blue, we see that islands that maintained a longer level 4, strict border strategy, they had a lower excess mortality than islands that maintained this strategy for a shorter period of time, whereas in non-islands there was no association. And we see that in the panel on the right, where the duration of time spent at level 4, so nothing to do with when it was started, but how long it actually lasted for once it was underway. There's a correlation coefficient here for islands showing a strong correlation between duration and low death, which doesn't exist for islands. And then under regression, under a formal island interaction effect, we see that the island effect, that islands that closed their border actually more than doubled the effect of border closure, formally under an interaction effect. So given all that foregoing analysis, we now have sort of a structural model of what might be going on. We've got preparedness here, which has an effect on pandemic mortality via some sort of mediating implementation constraints. We have government corruption as an influence on mortality through its effect on implementation. Particularly in islands, we've got this can determine control strategy choice, and via border strategy has an impact on mortality. And we know wealth has a direct impact on mortality, probably through things like healthcare access and so forth, but it also has an impact through preparedness. The wealthier jurisdictions tend to have higher preparedness index scores, and it probably has some effect via corruption as well. What we don't see in the model yet is these large sort of macro structural things like democracy, the degree of democracy, and inequality. And in a final paper, we sought to untangle some of that. So just one slide on democracy, one on inequality. What we see is that democracy does have an advantage in its association with death, but it's conditional. It's seen in our data in islands only. And applying the same methods as above, basically we can reconstruct a predictive model where, for this hypothetical jurisdiction of 100 per 100,000 excess mortality, if that jurisdiction were to have a +10 point or a 0.1 increase in their liberal democracy index, then we see something like a 34, I think it was, per 100,000 decrease in, or we would expect to see decrease in excess mortality in islands. We don't see this phenomena in non-islands. In fact, all these confidence intervals include zero, so that the effect isn't there in non-islands. Now, this we can speculate. This may be something to do with the strategies available to islands that may involve border closure, lockdowns for elimination or whatever, where the population sees these as potentially feasible, and the regime has legitimacy and there's trust and social cohesion and all these things associated with democracy. Whereas in non-islands, perhaps the same strategies aren't available, they don't seem feasible, and democracy can't be leveraged. So we're not yet 100% sure what's going on here, but there is this effect that differs between islands and non-islands. And we're seeing a similar thing with inequality, except it's sort of reversed. This time it's in non-islands. An increase in your, a decrease in your Gini coefficient, meaning less inequality, leads to a predicted reduction in excess mortality. So inequality is bad, less inequality good, in this case. And interestingly, with the Gini coefficient, we did see a statistically robust GDP growth effect in the first year of the pandemic, where more unequal jurisdictions had a deeper contraction, a GDP decrease in that first year of the pandemic. So inequality tended to predict worse economic outcome in the first year. So before I get on to just our final conclusions, just important to highlight the limitations of this work. So, although we looked at all jurisdictions, or as many jurisdictions as we could around the world, for some of the fully adjusted models where we start including trust as well, the sample sizes do decrease quite a lot. So it may not; those findings may not generalize once all control variables are included. There are possibly as yet unknown systematic differences between jurisdictions with data and without data, so that feeds into that point above. Ultimately, I emphasize this as a correlation study. We're not trying to infer causation; it's just associations between all these variables. The model fit in the macroeconomic analyses. The GDP analysis was poor, and GDP has limitations as a metric, so I wouldn't read too much yet into the GDP angles. We focused on the first 2 years of the pandemic, before widespread vaccination, later waves, and other geopolitical events might have confounded the analysis. And importantly, perhaps, we haven't accounted for geographic clustering, so where you get sort of contagion effects of, among jurisdictions, as the importance of this as highlighted in a paper by Kim in 2025. So that's probably an avenue for further research. Though we did do a fixed effects robustness analysis in the democracy and inequality study, according to the WHO super regions, which didn't reveal any confounding by regional analysis. Whereas I think the strengths of this approach actually outweigh those limitations. So we've got global data coverage in a relatively high impact pandemic, with appropriate age standardization, cumulative excess mortality, not reported data, with appropriate transformations, theoretically grounded controls, a plausible causal diagram, explicit stratification by islands and non-islands where we think a priori something different could be going on, and extending some of the analysis to these other macro factors as well. And no prior work jointly satisfies all those conditions when analyzing the preparedness indices and pandemic outcomes. So just to wrap up with some conclusions. So one of the main points I really want to make today is that data quality and the appropriateness of analyses really matter. And what we see is that those early studies, particularly ones using reported deaths, not transforming variables and perhaps not appropriately adjusting for multiple comparisons and all this sort of technical stuff, they actually found like completely opposite findings to the later studies after the dust has settled with a more careful analysis. So we've got to be really careful not to just jump ahead into analyses in these sorts of situations. And I know because there is a risk that slogans then persist, preparedness doesn't matter. We hear this because people might have read a couple of papers earlier in the pandemic, and then that has affected their view. preparedness as measured by the GHS index and its category scores. Seems pretty clearly that it does matter for non-islands in the according to these analysis. So, I would be very much still promoting non-island jurisdictions to adhere to the Global Health Security Index as it stands at the moment. However, islandness is a proxy probably for ability to implement alternative strategies like strong border management, which support an exclusion and elimination strategy. And therefore, future iterations of preparedness indices may need to treat islands differently or acknowledge this difference, and perhaps somehow deal with issues of the different border control options available to islands, quarantine options for travel across those borders, and the factors that allow for the implementation of internal elimination strategies, because these were very effective for islands during COVID-19. We need to acknowledge that specific interventions operate within broader systems of governance. So factors such as wealth, trust, democracy level, corruption, inequality all influence the deployment of these interventions, and the ability to implement strategy, such as whether it's border controls or exclusion elimination strategies in islands, is a really important component of preparedness, and probably constrains really to some degree what to prepare, because the context for the strategy needs to be appropriate. So here is a list of the 4 of our own papers, which I've mentioned in this talk. There's obviously the Global Health Security Index one was the main one here, but these 2 other papers, one on strategy and one on democracy and inequality. The democracy and equality one is the only unpublished one yet. It's available as a preprint on medRxiv, but I've actually got an updated version, a much better version. So if you want that, please just feel free to email me. I'll give you the latest version, and hopefully that'll be published in the next months. Yeah, look, I'd just like to say as well that we would love to do more work in this space. But it's unfunded research, and so we'll probably move on now to some other projects. That said, if anyone was interested in partnering on more of this kind of work and had resourcing available, I'd be more than happy to talk to people about that as well. So thank you very much.